Okay, let's unpack this. We are about to delve into a class of pharmaceutical agents that it fundamentally alters the relationship between your brain and your muscles.
It's a pretty profound concept when you stop and think about it.
It is. I mean, we are talking about the ability of doctors to voluntarily, chemically, shut down almost every single muscle in your body. And that includes the ones that keep you breathing.
It's a terrifying thought on its own, for sure, but it's also, one of the absolute pillars of modern surgery. It allows for a level of precision and stillness that would be completely impossible otherwise.
Exactly. So today, we are taking a deep dive into skeletal muscle relaxants.
It's an incredibly powerful category, and what's so fascinating here is that the field isn't. It's not a single thing. We're looking at a pharmacological spectrum that splits almost immediately into two major, very distinct worlds, and it's all defined by where the drug acts in the body.
Okay, so what's the first world?
First, you have the peripherally acting agents. These are the drugs of the operating room. You'll hear them called neuromuscular blocking agents, or NMBAs.
NMBAs. So these are the heavy hitters,
Yeah.
the ones that act right at the junction between the nerve and the muscle fiber, inducing that absolute flaccid paralysis.
That's them. They are absolutely critical tools used right alongside general anesthetics during complex procedures to make sure there's no patient movement whatsoever.
Got it. And the second group?
The second major group is just as vital, but it serves a completely different, often chronic purpose. These are the centrally acting agents.
So they're working higher up.
Exactly, in the brain or the spinal cord, what we call the cerebrospinal axis. And their mission isn't paralysis at all, it's to gently reduce excessive muscle tone and painful spasms.
So we're navigating from this acute life and death chemical precision in the OR all the way to the long-term daily management of neurological spasticity.
It's a huge range.
It is. Our mission today is ambitious. We're going to trace these mechanisms from their surprising historical origins, which, and this is true, genuinely include arrow poisons used for hunting, all the way up to cutting-edge precision monitoring in the OR. We've pulled together a fantastic technical chapter covering the chemical structure, specific drug applications, and crucial safety profiles to guide our deep dive and give you that shortcut to being well-informed.
Right. And when we approach the history of neuromuscular blockade, we absolutely have to start with a story that stretches back centuries. It sounds like something out of an adventure novel, really. We have to start with curare.
Curare, I've heard that term, but it's often used pretty generically. It represents a whole class of plant extracts, right?
Right.
What was its original function?
Well, historically, these were lethal extracts used by indigenous peoples of the Amazonian basin. We're talking about South American tribal hunters, and it was a highly effective arrow poison.
For hunting animals.
Exactly. The purpose was clear. The animal, even if it wasn't instantly killed by the arrow itself, would become completely paralyzed and immobile almost immediately.
Wow. And where did it come from?
The key natural sources were specific vines and trees. Things like Strychnos toxifera and Chondrodendron tomentosum, and it was from these plants that scientists first isolated the active principles like D-tuberculin and the toxiferins. These were the very first neuromuscular blockers ever studied.
That transition is just incredible. From a jungle poison designed to paralyze prey to a precise pharmacological tool used in a sterile operating room.
Wow.
But that leap required solving a huge scientific mystery.
It did. They had to figure out exactly where this poison was acting.
And that brings us to that famous 1856 experiment that really defined the entire field.
Yes, Claude Bernard's landmark experiment. It is absolutely foundational knowledge here. It isolated the exact site of action with such beautiful simplicity. He took a pithed frog.
A piffed frog, so.
Yeah.
Just to be clear for everyone, that means the central nervous system, the brain, and spinal cord had been destroyed.
Right, to eliminate any centralized effects. You're looking only at the local nerve and muscle. So he stimulated the sciatic nerve.
Which, under normal conditions, would make the attached gastrocnemius muscle in the frog's leg twitch.
Exactly. Then Bernard introduced curare into the system, and the results were so specific they led to an undeniable conclusion.
What happened?
When curare was present, stimulating that same sciatic nerve no longer caused the muscle to twitch. Nothing. But here's the crucial control step.
Okay.
If he bypassed the nerve and stimulated the muscle directly with an electric shock, the muscle still contracted perfectly normally. And on top of that, the nerve itself was still conducting electrical signals just fine.
So wait, if the nerve could still send the signal and the muscle could still contract when you shocked it directly, The failure point couldn't be the nerve and it couldn't be the muscle.
Right.
The blockage had to be happening in that microscopic gap between the nerve ending and the muscle fiber.
The neuromuscular junction. Bernard's conclusion that Curar specifically blocked the transmission right there at the junction, it stood the test of time. Modern studies confirm it. This junction is the one singular site of action for all these peripheral NMDAs.
Okay, so let's zoom in on that junction because this is where everything happens. The entire difference between the two main types of these peripheral blockers, the competitive and the depolarizing ones, it's all about how they interact with that single receptor site.
It is. The site of action is the muscle end plate of the skeletal muscle fiber. The receptor we're talking about is the non-nullermol nicotinic cholinergic receptor.
Right.
If you could see it, it's a large protein structure, almost like a rosette, made of 5 subunits that surround a central pore. And that pore is the sodium channel.
And the body's natural signaling chemical, acetylcholine, binds to a couple of specific spots on that rosette.
Correct. Acetylcholine, or H-again, binds to the 2 alpha subunits. When it binds, it causes a conformational change, basically a twist in the protein's shape, that opens the central gate.
And lets sodium ions rush in.
Exactly. Positively charged sodium ions, plus dollars, rush into the cell. This flood of positive charge creates what's called the end plate potential, or EPP. And if that EPP is strong enough, it triggers the full-blown muscle action potential, the MAP, and boom, the muscle contracts.
So now we can see how these blockers hijack that perfect system. Let's start with the original model, the ones that came right out of the jungle, the non-depolarizing or competitive blockers.
These drugs, like D-tubocurine, have a very high affinity for that end-dollar receptor. They love to stick to it. But, and here's the critical distinction, they have 0 intrinsic activity. They are pure antagonists.
So they're like a perfectly shaped key blank. They fit right into the receptor's lock, taking up the spots where acetylcholine would normally go, but they can't turn the lock. They just sit there.
Exactly. Blocking access. They are chemical roadblocks. By occupying those spots, the natural ACA that's released by the nerve just can't get to enough receptors to trigger a significant electrical change.
And so the EPP, that end plate potential, it falls below the critical level.
It falls below the threshold needed to propagate the full MAP. The muscle fiber stays electrically silent, and what you get is flaccid paralysis.
And if we look at their structure, the old nickname for this group makes perfect sense. They were called pachycurar.
It's a great term. It means thick curar, and that's what they are. Generally thick, bulky molecules. And that bulkiness is actually central to how they work.
How so?
When they bind to those subunits, their sheer physical size prevents that necessary conformational twist that would open the sodium channel. They are physically jamming the machinery shut.
The key point here, then, for these competitive blockers is that their action is surmountable. Because it's just a race for the receptor, we can actually beat the antagonist.
Absolutely vital. And this is the basis of our entire reversal strategy in the operating room. Since it's a competition for binding sites, if we can drastically increase the concentration of the natural agonist, the HEAs, we can just overwhelm the blocker.
You can win the numbers game.
You win the numbers game and restore function. And clinically, we do this by giving anticholinesterase like neostigmine. These drugs temporarily stop the enzyme that breaks down 8, so H levels at the junction just skyrocket, and they literally force the bulky competitive blockers off their receptors.
Okay, so that's the competitive blocker. Now we have to talk about the complete pharmacological opposite. The depolarizing blockers, with the classic example being acetylcholine or SE.
Yeah, right, so if the competitive blockers are those key blanks, S is totally different. It has high affinity, and it has submaximal intrinsic activity.
So it's a key that fits and turns the lock. It acts just like acetylcholine.
Initially, yes. S is an intense agonist. It binds to the receptor, it opens the sodium channels, and it causes this immediate, powerful depolarization of the muscle end plate. Since the stimulation is transient, it triggers this rapid, repetitive firing of the muscle fiber.
And that's something you can actually see, right? That's the signature clinical sign of giving S.
You can. Brief involuntary muscle twitching, known as fasciculations. Those fasciculations are the visual confirmation that the drug is aggressively activating the receptors. But the real blockade comes right after the twitching stops. The mechanism shifts from activation to inactivation.
What do you mean?
Well, unlike natural ASHI, which is destroyed almost instantly by an enzyme at the motor end plate, ASHI doesn't dissociate quickly, and it's not broken down by that specialized enzyme.
So the key gets stuck in the open position. It causes this continuous, prolonged depolarization.
Precisely. The membrane potential, the internal voltage of the muscle fiber, it drops and it just stays low, around -50 millivolts. And this continuous electrical excitement, paradoxically, causes paralysis.
Oh.
Because the sodium channels in the area immediately surrounding the end plate, they become refractory, they get inactivated, they can't reset. And this creates a zone of inexcitability around the end plate, which makes the muscle fiber completely unresponsive to any new signal. The result, flaccid paralysis.
And structurally, these are the leptocurar agents. Slender curar.
Yep. They're long, slender, flexible molecules. They perfectly mimic the structure of two acetylcholine molecules stuck together, which allows them to activate the receptor so powerfully.
Now, you mentioned that there's another layer of complexity here. Acid has this dual mechanism if you use it for too long.
Yes, this is the infamous phase I versus phase II shift. It's clinically very important.
So what's phase 1?
Phase I is that classic rapid onset, persistent depolarization block we just talked about. But with prolonged exposure, say a continuous infusion, the membrane voltage actually starts to creep back up. The end plate begins to repolarize.
But it's still paralyzed.
It is, because the receptor itself has become functionally altered. It gets desensitized to the effects of acetylcholine. And this is what we call phase II block, or a desensitization block.
And I've heard that this phase 2 state can start to look dangerously similar to a competitive block.
Exactly. Superficially, it resembles it. For example, when you're monitoring the patient, you start to see a characteristic fade in muscle response, which is totally absent in phase 1. And crucially, in phase 2, the block can be partially reversed by anticholinesterase.
Wow, okay.
But administering neostigmine during the initial phase I block would be an absolute disaster. It would make things much, much worse. This dual nature is why ESI, for all its speed, requires very careful monitoring.
So this distinction between the bulky competitive pachycurar agents and the slender depolarizing leptocurar agents, it dictates everything that happens next, how they're given, what the surgical team sees, and most critically, how you manage recovery.
The clinical distinctions are sharp. Let's start with how they respond to a pharmacological challenge. We said competitive blockers cause pure flaccid paralysis.
Right, while the depolarizing agents start with those fasciculations, and then you get the flaccid paralysis.
Correct. And then there's the response to reversal agents. This is paramount. For competitive blockers, neostigmine, or anticholinesterase, effectively reverses the block.
But for the classic functional phase I depolarizing block, you said neostigmine is a no-go. Why is it so bad?
It's the critical difference. Neostigmine inhibits the enzyme that destroys both natural ACoU and ESH. So in a competitive block, that's great. We want more of the natural competitor, AHO, to win the race.
Right.
But in a FASCI depolarizing block, the receptor is already jammed open. It's burning out the sodium channels. If we then inhibit the breakdown of AIQ even further, we just worsen the persistent depolarization.
You're just deepening the paralysis. You're intensifying the chemical jam.
Exactly. You prolong the period of apnea. And we also see differences in how they interact with inhaled anesthetics.
Oh, right. Like ether or isoflurane.
Yes. Those significantly potentiate competitive blockers, meaning you need a much smaller dose of the NMBA to get the same effect. But they generally have very little effect on a phase I depolarizing block, though they can encourage the shift into that dangerous phase too.
The physical progression of the paralysis is also like a roadmap for the clinician, isn't it?
Yeah.
How does the body shut down with a competitive agent?
With non-depolarizing blockers, the smaller, faster responding muscles are hit first. So you see it in the fingers, the extraocular muscles controlling eye movement.
Oh, yeah.
Then the block progresses inwards, hands and feet, then the arms and legs, the neck and face, the trunk, the intercostal muscles, and finally the diaphragm.
So respiration stops last. That's a crucial safety feature.
It's a huge safety feature. It allows the anesthesiologist to gauge the depth of paralysis just by watching subtle shifts in muscle function.
And recovery is the mirror image, right?
Exactly. It happens in the reverse sequence. The diaphragm starts contracting first. Breathing resumes first. That's your immediate safety net. The patient gets control of their core muscles before they get fine motor control back, like moving their eyes or gripping a surgeon's hand.
What about the sequence for depolarizing blockers like ESH?
It's a bit different, although the action is so incredibly rapid, we're talking full paralysis in 60 to 90 seconds, that the sequence is often compressed and hard to even see.
It's just that fast.
It is. It typically hits the neck and limbs first, followed very quickly by the face, jaw, eyes, and then almost instantaneously the trunk and respiratory muscles. That speed is precisely why SEH is the go-to drug for an urgent tracheal intubation, when getting an airway secured in seconds is paramount.
This precision is amazing, but how do they manage this delicate balance in real time? I mean, you can't just guess when the diaphragm is ready to start breathing again.
No, you can't. And that's where quantitative objective monitoring comes in, done right there in the operating room. We rely on nerve stimulation,
Okay.
typically targeting the ulnar nerve to watch the contractions of the adductor pollicis muscle in the thumb. That's one of those small muscles that tends to recover last.
And the standard protocol for this is the train of 4, or TOF protocol.
That's the one. The TOF applies 4 rapid electrical stimuli over 2 seconds. The physician then measures the TOF ratio, so the strength of that fourth twitch divided by the strength of the first. If the patient is fully recovered, that ratio is 1 point/mAu. If they're partially blocked, the ratio drops.
And the specific pattern of how the muscle weakens tells you which drug is still active. This is where the fade phenomenon comes in.
Yes, for competitive blockers, that fourth twitch is noticeably weaker than the first. That's the fade.
And why does that fade happen?
Because the competitive blockers also act projunctionally. They partially block the nicotinic receptors that are located on the nerve ending itself. And those receptors are essential for mobilizing and releasing more acetylcholine when the nerve is stimulated over and over.
So when you try to fire the nerve 4 times quickly, the competitive blocker is preventing the nerve from adequately restocking its ACH supply for those later firings. The tank runs low.
Precisely. A low TOI ratio with visible fade confirms that a significant competitive block still exists. It tells you the patient is still weak and unsafe to breathe on their own. This ratio is a huge patient safety metric. We know from studies that spontaneous breathing may be safely resumed when that TOF ratio gets above 0.7.
And what about the depolarizing block in phase 1? Does it fade?
No fade. In phase I, depolarizing block, there is no fade. All 4 twitches are equally depressed, so the TOF ratio remains 1.0, even if the overall strength is really low. This is a critical differentiator.
I've also heard of a technique called post-tetanic potentiation.
Post-tetanic potentiation, or PTP, is another diagnostic tool. If you deliver a rapid, high-frequency tetanic burst of stimulation during a partial competitive block, you temporarily flood the synapse with calcium.
Okay.
This massively increases the projunctional mobilization of HJET, so that huge release translates into a much, much stronger response to a single twitch you give right after. This PTP effect is present in competitive block. But, again, it's absent in a phase I depolarizing block. These subtle monitoring patterns give the clinician indispensable information.
We've established that NMBAs are precision tools for that skeletal muscle end plate. But, especially with the older, bulkier compounds, their chemical structures were less specific. This meant they caused some significant and sometimes dangerous off-target effects.
That's absolutely true. It's tempting to think they only act on skeletal muscle, but their effects can extend well beyond that, which makes them really challenging for patients with, say, pre-existing heart or lung conditions.
Let's start with the non-muscle nicotinic receptors. We're talking about the autonomic ganglia.
Yes. The ganglia of the autonomic nervous system, the system that controls all our involuntary functions like heart rate and blood pressure, they also contain nicotinic receptors, but these are a different type, designated non-nuller.
And the older drugs hit those too.
Right. Older competitive blockers, especially the original D-tubocurarine, had a high tendency to block these non-nuller receptors, and that causes significant ganglionic blockade. This disrupts the nerve signaling that maintains your vascular tone.
So the same bulky pachycurare that blocks movement also blocks the control centers for blood pressure.
Exactly. And this is one of the main reasons DTC caused such severe, uncontrolled drops in blood pressure. Thankfully, the newer, more refined competitive blockers like vecuronium and rocuronium are far more selective for the muscle's non-nuller receptor.
So they have fewer of those side effects.
Negligible effects on the autonomic ganglia, leading to much better cardiovascular stability. It's interesting, succinylcholine actually causes ganglionic stimulation. It activates these receptors.
The second major off-target effect is inflammatory. Histamine release.
Oh, histamine release is a huge problem with D-tubocurarine. The drug's bulky, highly cationic or positively charged structure interacts with mast cells and causes them to just dump massive amounts of histamine.
And that's not an allergic reaction.
No, it's a direct chemical effect, and histamine, as you know, is a potent vasodilator. It contributes significantly to hypotension, flushing, and in sensitive patients, it can cause life-threatening bronchospasm.
So the original arrow poison was causing paralysis and a massive systemic reaction.
It was. Other drugs like atracurium and mivacurium also have significant histamine-releasing potential, though not as bad as DTC. This is a critical factor when an anesthesiologist is choosing an agent for, say, an asthmatic patient.
Let's follow those effects into the cardiovascular system. So with DTC, you get the ganglionic block and the histamine release,
Mm.
which result in a significant and often very undesirable fall in blood pressure.
Mm.
But then you have pancuronium, another older competitive agent, which did the opposite. It tended to cause tachycardia, a fast heart rate, and a rise in BP
Why?
because it preferentially blocks the vagal or parasympathetic ganglia receptors in the heart.
So you had a difficult choice. Dangerously low pressure with DTC or a dangerously high heart rate with pancuronium.
Yes, the early era of NMBAs required constant vigilance just to manage these side effects. Fortunately, the modern choices, vecuronium, rocuronium, cisatracurium, they're what we call clean agents. They are highly selective and have almost no effect on BP and heart rate, which is a massive clinical advantage. It lets the team focus on the surgery.
Let's talk pharmacokinetics.
Oh,
How the body handles these drugs. You mentioned all NMBAs are polar quaternary compounds. What's the main takeaway from that? The key takeaway is that their chemical nature dictates everything. Being highly ionized, they're not absorbed if you take them orally, so they have to be given intravenously. And crucially, they don't cross the blood-brain barrier or the placenta.
which is good news.
It is. It means when you give it to a patient during surgery, you can be confident it won't cause central effects like sedation or affect a fetus.
And their elimination pathways determine how long they last.
Correct. The longer-acting drugs, the ones lasting 60 minutes or more like pancuronium, are primarily excreted unchanged by the kidneys. So if a patient has any kind of renal impairment, the drug hangs around and the paralysis can be dangerously prolonged.
And then you have the shorter or intermediate acting agents, which last 20 to 50 minutes. They rely on the liver and plasma for metabolism. But the real pharmacological marvel here is the unique elimination pathway of atracurium and its preferred isomer, cisatracurium.
This is where it gets really interesting. Atracurium and cisatracurium are eliminated by a remarkable process called Hoffman elimination. This is a spontaneous, non-enzymatic degradation.
Spontaneous. What does that mean?
It means the molecule is inherently unstable under physiological conditions. It just chemically degrades and breaks apart on its own, based simply on the body's normal pH and temperature. It doesn't need an enzyme, and it doesn't rely on the health of the liver or the kidneys.
So it's like a built-in, time-release, self-destruct mechanism that works just by being in the body. That sounds like a huge clinical advantage.
It's a massive advantage, especially for the sickest patients. Their duration of action is completely independent of hepatic or renal failure, making them the preferred choice for patients who are critically ill. And we now favor cisatracurium because it causes much less histamine release than the original atracurium.
So let's quickly profile the key players based on all this. D-tubocurium is basically just a historical footnote now, right?
Yes, historically vital for the field, but clinically it's defunct. The long duration histamine release and cardiovascular effects are just too much.
Then we have succinylcholine, the undisputed champion of speed, but also the most problematic.
It delivers rapid, complete paralysis in about a minute, and you get rapid, spontaneous recovery in 5 to 8 minutes. That speed makes it essential for urgent procedures like securing an airway. But the disadvantages are steep: muscle soreness, the severe risk of hyperkalemia in burn or trauma patients, and that critical risk of hours of prolonged paralysis in patients with certain genetic enzyme deficiencies.
Which we'll circle back to. So, if speed is needed, but we want to avoid all the issues with SDM, the field moved towards rocuronium.
Rocuronium is the fastest onset non-depolarizing blocker we have. At high doses, you can achieve intubating conditions in under 90 seconds. This makes it a true life-saving alternative to SU without the risks of hyperkalemia or malignant hyperthermia.
And finally, what about a truly short-acting competitive agent?
That would be mivacurium. It has the shortest action among the competitive agents, lasting only about 15 to 30 minutes. It's rapidly metabolized by plasma cholinesterases. And crucially, unlike SEO, if a patient is slow to recover due to that same enzyme deficiency, the mivacurium block is competitive, which means it can be reversed rapidly with neostigmine.
So it has a built-in safety escape hatch that SEA lacks.
Exactly. That reversibility adds a layer of safety. These powerful molecules, they're operating in this complex environment of the operating room, so they rarely act alone. Their effectiveness, and often the patient's safety, is highly sensitive to the presence of other medications.
Right, drug interactions are critical here. You mentioned that competitive blockers are significantly potentiated or made stronger by certain inhaled general anesthetics.
Absolutely. The degree of potentiation varies, but the rule holds true. Volatile anesthetics intensify the competitive blockade. This means you need a smaller dose of the NMBA. Just for context, the order of potentiation is roughly ether, which was the most potent historically, then isoflurane and halothane, and then nitrous oxide is the least.
And the potentiation by antibiotics is a less intuitive but really dangerous interaction.
Yes, particularly the aminoglycoside antibiotics. They significantly potentiate competitive blockers through a projunctional effect.
Projunctional, so on the nerve side of the gap.
Correct. Aminoglycosides reduce the release of acetylcholine from the nerve terminal because they compete with calcium ions. Calcium is essential for signaling the AC vesicles to release their contents. If you reduce calcium availability, you get less AC released with every nerve impulse.
So the nerve signal is already weak before it even hits the receptor. That means even a small dose of a competitive blocker could cause an intense, prolonged paralysis.
Exactly. This requires extreme caution and dose reduction. There are documented cases where even just applying streptomycin powder locally during a surgery caused profound, prolonged apnea because of this potentiating effect on a residual competitive blocker.
Wow. What other common drugs enhance the block?
Calcium channel blockers like Repamil. Also, something as simple as a diuretic, if it causes low potassium levels, hypokalemia, that can significantly enhance the competitive block because hypokalemia tends to hyperpolarize the muscle membrane, making it harder to excite.
So given all these interactions, the ability to rapidly and predictably end the paralysis is paramount. Let's talk reversal strategies, starting with the classic approach. Anticholinesterase like neostigmine.
Neostigmine is routinely used to hasten recovery from intermediate or long-acting competitive blockers. We know its function. It inhibits the enzyme that breaks down ACU, it floods the neuromuscular junction with the natural agonist, and it overwhelms the competitive blocker.
But the downside of that flooding is all the muscarinic side
A
effects.
huge downside. Acetylcholine acts not just on the nicotinic receptors in muscle that we want to reverse, but also on muscarinic receptors all over the body, especially in the parasympathetic nervous system.
And that causes problems.
It does. Uncontrolled muscarinic stimulation leads to the bronchospasm, excessive secretions, a slow heart rate, and hypotension. So it is absolutely mandatory to co-administer an antimuscarinic agent like atropine or glycopyrrolate at the same time as neostigmine.
To cancel out the bad effects.
Right. It neutralizes the unwanted side effects while preserving the beneficial reversal effect at the muscle junction.
That sounds complex. A dance between two different drugs just to get one result. This is why the introduction of Sugammadex was such a massive pharmaceutical innovation.
Sugammadex represents a complete revolution in reversal, specifically for rocuronium and vecuronium. Its mechanism is entirely novel. It's a modified dicyclodextrin. I like to think of it as a highly specialized molecular vacuum cleaner.
A chemical cage that physically traps the muscle blocker.
Precisely. Sugammadex has this central cavity that is perfectly shaped to physically encapsulate the rocuronium or vecuronium molecule. It forms a tight, water-soluble complex that is pharmacologically inactive and rapidly excreted by the kidneys.
So instead of competing for the muscle receptor, which is what neostigmine does, Sugammadex just pulls the drug right out of the patient's bloodstream.
Exactly. As the concentration of free blocker molecules in the plasma plummets, the blocked molecules rapidly dissociate from the receptors at the junction to maintain equilibrium. This restores neuromuscular transmission within minutes. Incredibly rapid, often full function is restored within 3 minutes. It can reliably reverse even very deep blockades. Its significance is immense because it bypasses all the risks of neostigmine, offering unprecedented control and predictability.
Despite all this precision, the use of NMBA still carries inherent toxicities and complications. What's still the most crucial safety risk?
Respiratory paralysis and prolonged apnea. That remains the single most important complication. If reversal is incomplete or the kinetics are misjudged, the patient needs immediate and sustained mechanical ventilation until their muscle function spontaneously returns. But then we also have these specific, often terrifying risks tied exclusively to succinylcholine.
The primary one being hyperkalemia.
Yes, succinylcholine causes an augmented efflux of intracellular potassium from the muscle fibers. Now, in a healthy patient, this is usually negligible, a tiny increase. However, in patients with conditions where there's an upregulation of receptors like extensive burns, massive crush injuries, or nerve damage, the potassium efflux is dramatically amplified.
And that's dangerous.
It can lead to life-threatening hyperkalemia, causing ventricular arrhythmias and even cardiac arrest. This is why SC is absolutely contraindicated in these patient populations.
And then there's that rare, inherited risk that every anesthesiologist dreads, malignant hyperthermia.
Malignant hyperthermia, or MH, is a serious genetic reaction. It's triggered by succinylcholine and the volatile fluorinated inhaled anesthetics like halothane.
Okay.
In genetically predisposed individuals, MH is a hypometabolic crisis. It's caused by persistent, uncontrolled calcium release from the muscle's sarcoplasmic reticulum. This leads to massive, uncontrollable muscle rigidity, a soaring body temperature, and rapid multi-organ failure.
So to sum up the primary uses of NMBAs, they're essential adjuvants to general anesthesia.
They facilitate complex surgery, allow for easy tracheal intubation, and enable specialized procedures like endoscopies and orthopedic manipulations by ensuring complete muscle stillness. SG is reserved for brief, urgent procedures. For routine surgery, the modern intermediate-acting cardiovascularly stable agents, vecuronium, cisatracarium, and rocuronium, are the preferred non-depolarizing blockers. They offer the best balance of safety, control, and reversibility.
Now we need to shift our focus entirely. We're moving away from the acute, high-stakes world of the junctional block to the chronic management of debilitating muscle tone. The goal is no longer absolute paralysis, but rather reducing spasticity and painful muscle spasms, while ideally preserving voluntary movement.
This is a fundamentally different pharmacological challenge. Let's start with a true outlier in terms of its mechanism, dantrolene.
Dantrolene is unique because it acts directly on the muscle fiber itself. It completely bypasses the nerve and the neuromuscular junction.
Its target is deep inside the muscle cell. It acts on the RIR1 or RIA9 receptor calcium channels in the sarcoplasmic reticulum. These receptors are the gatekeepers that control the flow of calcium from internal stores into the muscle cytoplasm.
So the nerve signal arrives fine, the junction transmits the signal fine, but what happens inside the muscle?
The signal arrives, but dantrolene prevents that massive flood of calcium release that's needed for excitation-contraction coupling. Without that surge of calcium, the contractile machinery just can't engage. It effectively uncouples the electrical signal from the physical contraction.
Given that mechanism blocking uncontrolled calcium release, it makes perfect sense that dantrolene is the specific emergency treatment for the genetic crisis we just talked about, malignant hyperthermia.
It is the definitive drug of choice for MH. It physically blocks the very mechanism, that uncontrolled calcium leakage, that causes the hypermetabolic state. Beyond MH, it is used orally to reduce spasticity in chronic upper motor neuron disorders like multiple sclerosis, cerebral palsy, and hemiplegia.
But I understand its benefits for chronic spasticity are often limited because of a difficult side effect profile.
They are. While it does reduce spasticity, it also reduces voluntary power. For a patient fighting to recover function after a stroke, that trade-off is often unacceptable. And we also have to remember its major risk. Long-term oral use carries a dose-dependent risk of serious liver toxicity.
Okay, let's move to the true centrally acting relaxants. What is the defining characteristic of this entire group?
Their goal is to reduce tone by selective action within the spinal cord and brain. They do this primarily by depressing spinal and supraspinal polysynaptic reflexes. These polysynaptic pathways are complex circuits with multiple nerve connections, and they're largely responsible for maintaining excessive muscle tone and reflex activity.
And the key functional distinction from NMBAs is that these central agents decrease muscle tone without eliminating voluntary power. And they're typically given orally for chronic management.
Yes. They disrupt the reflex arcs, but the main motor pathway stays largely intact. However, because these polysynaptic pathways are also involved in consciousness and wakefulness, all central agents come with some degree of sedation, even the ones that are described as selective.
Let's review the four main classes, since they target different parts of the central axis, starting with the oldest group, mefenizine congeners like carisoprodol and chlorzoxazone.
These were the early attempts at central relaxation. Their primary site of action is believed to be the spinal internuntial neuron, the mediating nerve cell in the spinal cord. They're prescribed for acute muscle spasms, often combined with pain relievers for things like backache or sprains.
But how well do they work?
Well, the clinical reality is that their efficacy as pure muscle relaxants is often poorly established, and common side effects include sedation and significant gastric irritation, which really limits their appeal today.
The second and much more widely used class are the benzodiazepines, primarily diazepam.
Benzodiazepines act supraspinally so, higher up in the brain. They act on BZD receptors to enhance the activity of GABA, which is the body's major inhibitory neurotransmitter. This enhancement of GABAergic transmission globally reduces muscle tone.
Where do we see it used most?
Diazepam is still highly valued in acute spasm conditions, particularly spinal injuries, certain orthopedic trauma, and critically, tetanus, where you need central inhibition to stop those severe reflex spasms.
But the drawback is often the deep sedation that comes with it.
That's the persistent clinical hurdle with diazepam in chronic use. The same mechanism that calms the spasm also causes significant CNS depression, making it unsuitable for patients who need to function alertly.
That brings us to baclofen, which is often considered the preferred agent for serious chronic neurological spasticity.
Baclofen is an analog of BABA, but it is highly selective for a different receptor, the GABA receptor. When activated, this receptor hyperpolarizes the neuron by increasing potassium conductance. This depresses both polysynaptic and monosynaptic reflexes in the spinal cord, reducing severe spasticity.
And because it acts so effectively at the spinal level, it's the preferred drug for symptomatic relief in major neurological disorders, like multiple sclerosis, ALS, and chronic spinal injuries.
Right. It generally causes less sedation than diazepam, which offers a better quality of life trade-off. However, baclofen treatment is not without risk. Abrupt withdrawal after chronic use can cause severe symptoms, including hallucinations, anxiety, and potentially life-threatening seizures.
So it requires very careful management.
Very slow tapering. In extreme cases where oral dosing isn't enough, baclofen can even be administered intrathecally directly into the spinal fluid to maximize its spinal effect while minimizing systemic side effects.
Finally, we have the central alpha-toid agonist class, exemplified by tizanidine.
Xanadine is a clonidine congener. Its primary mechanism is to inhibit the release of excitatory amino acids, like glutamate, in the spinal interneurons. So by quieting the communication between excitatory neurons, it reduces muscle tone.
And its efficacy is good.
It has shown good efficacy in spasticity related to MS, stroke, and spinal injury, and it often has a favorable side effect profile compared to baclofen or diazepam in terms of sedation.
So why isn't tizanidine always the first choice?
It still carries risks. A dose-dependent elevation of liver enzymes is a notable side effect. And because it's an alpha-2 agonist, like clonidine, it can cause significant hypertension and bradycardia. This means it must be used with extreme caution in patients who are already taking antihypertensive medications.
So really, the clinical summary for these central agents shows the difficult reality of managing chronic spasticity.
It does. While they're useful for acute spasms and essential for conditions like tetanus for chronic spastic neurological diseases, the therapy often remains unsatisfactory. The physician has to constantly weigh the benefit of spasm reduction against the side effects of sedation, functional weakness, and potential organ toxicity. It's a management challenge that requires constant titration and patience. So, to synthesize the two worlds we've just explored, we've really seen two fundamentally different approaches to controlling movement. On one hand, you have the peripheral world, that acute surgical realm demanding absolute, immediate, and rapidly reversible paralysis with agents like rocuronium and succinylcholine.
Right, and the pharmaceutical elegance there lies in the physical structure, that whole pachycurare versus lepticurare thing, and an innovative reversal, like Sugamidex's molecular vacuum cleaning.
Exactly. And on the other hand, you have the central world. This is the chronic management of debilitating tone and spasticity using agents like baclofen and tizanidine.
And this requires a totally different approach, targeting the spinal cord to reduce reflex activity while trying to preserve as much voluntary function as you can, and just accepting that unavoidable trade-off of some sedation or specific organ toxicity.
The ability to target a specific effect, whether it's blocking the non-avoider receptor to stop all movement or selectively activating a spinal Tix-Jody receptor to just quiet a muscle tremor, it really underscores the complexity and the power of pharmaceutical chemistry in managing one of life's most basic functions, movement.
In understanding the nuance between a competitive block that causes fade and a depolarizing agent that causes fasciculations, That's the difference between achieving a seamless recovery and exposing a patient to profound danger.
It really is.
That distinction and the heavy reliance on these very specific chemical pathways leads us to our final provocative thought for you, the learner.
The need for total muscle paralysis in the operating room requires absolutely perfect timing. We discussed succinylcholine, which is fast and predictable, but its clearance relies entirely on a single enzyme in the plasma called pseudocholinesterase. And we mentioned that this enzyme is determined by an individual's genetics. In a small but significant percentage of the population, genetic variations lead to a deficiency or an atypical version of this enzyme.
Right.
And the clinical result is that when SNA is administered to one of these individuals, it just isn't broken down. The patient experiences a massively prolonged period of apnea, potentially lasting for hours, long after the surgery is over, and this genetic deficiency is silent. It's often unknown until the moment that high-stakes drug is given.
So consider this. What are the unique societal or ethical challenges that arise when life-sustaining functions, like the guaranteed recovery of spontaneous breathing, are made dependent on an invisible, variable genetic factor in a high-stakes acute care environment? If the consequences are so immediate and so severe, should mandatory preoperative genetic screening for pseudocholinesterase deficiency become standard practice, moving us closer toward truly personalized yet significantly more complex acute care medicine? Something to think about as you continue your own deep dive.